Hello, my name is Dr. John DeWitt, and I am Professor of Medicine in the Division of Gastroenterology and Hepatology at IU Health in Indianapolis, Indiana. And on behalf of my other co-authors, I would like to present our paper entitled Prevalence and Impact of Opioid Use in Patients Undergoing Peroral Endoscopic Myotomy. About 3 to 4% of the U.S. population would be characterized as long-term opioid users. In about 25% of chronic users, a condition called opioid-induced esophageal disorder develops. This is characterized by dysphagia, symptoms of heartburn or GERD, and chest pain. The most commonly associated esophageal motility disorders with OIED are diffuse esophageal spasm, type 3 achalasia, hypercontractile esophagus, and esophagogastric outflow obstruction. Treatment of OIED involves stopping narcotics when possible, but this is often unrealistic in most patients. Non-pharmacologic alternatives may be pursued, but there are no guidelines to help clinicians on management of these patients. Peroral endoscopic myotomy, or POEM, has previously been described as providing excellent relief for EGJ outflow obstruction, hypercontractile esophagus, and type 3 achalasia, but its use in OIED has not been described. The two aims of our study were first to identify the frequency of chronic opioid use in consecutive patients with one of the 4 esophageal motility disorders associated with OIED who were treated with peroral endoscopic myotomy at our hospital. The second aim was to compare relevant clinical outcomes of POEM for OIED to a control group of similar idiopathic esophageal motility disorders. This is a retrospective single-center study carried out at IU Health in Indianapolis between April 2014 and September 2021. It included consecutive patients with type 3 achalasia, EGJ outflow obstruction, esophageal spasm, and hypercontractile esophagus who underwent POEM. We included patients if they had Eckert scores at least 6 months after POEM, excluded those with age less than 18, follow-up shorter than 6 months, or an Eckert score was not documented at follow-up evaluation. Prior to POEM, all patients underwent upper endoscopy, high-resolution esophageal manometry, and functional lumen impedance splenimetry, or FLIP, of the esophagogastric junction. At 6 to 12 and 24 months after POEM, patients underwent repeat upper endoscopy, FLIP, and manometry, as well as, when possible, 48-hour pH testing off all anti-secretory therapy for at least 1 week. Clinical response after POEM was defined by one of 4 metrics, including an Eckert score less than or equal to 3, an EGJ distensibility index of at least 2.8, a maximum EGJ diameter of 14 millimeters, or a normal integrated relaxation pressure of less than 15. The presence or absence of gastroesophageal reflux disease was defined by the Leon classification, and chronic opioid use was defined as daily use for at least 90 days prior to manometry. Total use was defined by the amount of morphine milligram equivalents. During the study period, 126 patients underwent POEM for one of the 4 studied motility disorders, and 71%, or 89 of these, had at least 6 months of follow-up and comprised the study population. Overall, 54% were male, mean age was 62, the mean Eckert score was 6.9, and IRP was 21.8. Of the 89 patients, 18, or 20%, were chronic opioid users, with a median daily morphine equivalent dose of 40, and all 18 patients continued their opioid use after POEM. There was no difference between the opioid and non-opioid group for any of the studied demographics or baseline tests assessed. The most common esophageal motility disorder in the 89 patients was EGJ outflow obstruction, which was present in about half. Overall, about a third of patients had had previous Botox therapy. There was no difference between either group in the type of motility disorder or previous therapy performed prior to POEM. The mean length of myotomy performed was 12.2 centimeters. It was full thickness in about 2/3 and posterior in about 90%. There was no difference in the mean baseline EGJ distensibility index, maximal diameter, myotomy length, type of myotomy or orientation between the two groups. This table illustrates the clinical response by Eckert score, manometry, FLIP, and the diagnosis of GERD at least 6 months after POEM when stratified by the use of opioids or not after POEM. Clinical response by Eckert score was present in about 85% of patients, by IRP in 95%, by maximal EGJ diameter in 89%, and by distensibility index in 97%. And these values were similar between opioid and non-opioid users. Post-POEM GERD was present in a fairly high percentage, in 77%, but again, no difference between the two groups. Heartburn was present in about half of patients, but more commonly in the opioid group compared to the non-opioid group, and this was statistically significant. There was no difference in the frequency of esophagitis or PPI use between 6 and 12 months after POEM between the two groups. This slide illustrates clinical response and the diagnosis of GERD after POEM when the opioid users are stratified by the amount of daily morphine equivalents. For the 18 opioid users, 10 had less than or equal to 40 MMEs and 8 had over 40 MMEs. Similar to the previous slide, the values were not significant for both groups, except similarly heartburn was higher among opioid users, even when stratified by the amount of morphine equivalents used. Results at 24 months were available in about 3/4 of patients, including Eckert scores in 10 opioid users and 40 non-users. And similarly, overall clinical response by Eckert score was similar between the two groups at 2 years. From our study, we had several conclusions. First was that daily opioid use was present in 20% of the 89 patients with one of 4 motility disorders commonly associated with OIED. So therefore, clinicians who treat patients with motility disorders need to be aware of this association and question patients about potential use. Second, none of the 18 patients who used daily opioids prior to POEM were able to stop use after POEM, thus illustrating the limiting treatment options that patients have with this problem. Third, clinical success when defined by a normal Eckert score was achieved in 86% of patients with at least 6 months of follow-up, and there was no difference in clinical success by any of the 4 metrics measured when users or non-users of opioids were stratified. Similarly, there was no difference when stratifying by the amount of morphine equivalents that were used. We found that opioid users reported more commonly heartburn in 82% compared to 38% of non-users at least 6 months following POEM. This is the first study that's looked at the use of potential POEM in OIED patients. Further evaluation in other studies is necessary prior to offering this routinely in patients with this disorder.